Oh, do I actually feel queasy? Hi everybody. We're going to talk about the anatomy of the vagus nerve, but whenever I, talk about a subject, I do a lot of reading around to add stuff in, and there is so much bullshit about the vagus nerve on the internet. Apparently, if you have a coffee enema and you hold it for like 12 to 15 minutes, then something to do with it helps the liver detoxify your blood, and all your blood passes through the liver every 3 minutes. So because you have a coffee enema, it stretches the bowel and triggers the vagus nerve and switches on the none of it makes any sense. Ugh. Okay, so when reading on the internet about the vagus nerve, put on your protective crazy hat, drill down to the science. Now, the thing about the vagus nerve is that recent science has shown that there is some weird stuff going on with the connection between the brain and the gut through the vagus nerve. But there's good science underneath all this. So when something weird comes up, drill down to the science and don't just take like scientific studies as read. Have a look at, is it good science? Is it high quality science? Is it big science? Is it powerful science? Or is it weak science that's open to bias and interpretation and a chance of occurring through... I just feel so... If you start reading an article that talks about how the vagus nerve innervates the diaphragm, you should definitely stop at that point, right? Whatever, let's not worry about it too much. I am, after all, just another idiot on the internet. I might have a degree in anatomy and a PhD, and I'm employed to teach anatomy and that sort of thing, but does that mean I know what I'm talking about? I could have the wrong end of the stick and be waving it around like a madman like everybody else. What I'm really saying is, just be a little bit careful with your sources of information. Anyway, vagus nerve. Okay, where does everybody start when they talk about the vagus nerve? Well, I mean, we're going to talk about the anatomy of the vagus nerve, little bit of structure, little bit of function associated with that. So we're going to follow it from where it starts, follow it out and work out where it goes to, what it innervates along the way. By doing that, we can then talk about its main jobs. And that's the thing about the vagus nerve. This is usually the number one fact that everybody starts talking about, is that the vagus nerve, most cranial nerves go to cranial places. Some of them go to like trapezius, sternocleidomastoid. If you know your stuff, you know what I'm talking about. The vagus nerve is most famous because it wanders off down the neck into the thorax, and essentially it's trying to work its way down to the GI tract. So it's the wandering nerve, and vagus comes from the same origins as vagrant, vague. You know what I'm being a bit vague in what I'm wandering around the subject area. Vagrant, it's all the same. That's the vagus nerve. There are 12 cranial nerves, and the vagus nerve is cranial nerve 10. We tend to write this in Roman numerals, so CNX. The cranial nerves are peripheral nerves that come out of mostly the brain stem. So the vagus nerve is coming out of the medulla oblongata. This is another trick. Okay, why am I sat at home? For those of you in the future wondering why I'm not in an anatomy lab, there is a bit of a virus swishing around the world, so I'm stuck at home. I'm not allowed to go into work. We're all kind of locked down a little bit to stop the spread of the virus. So one of my limitations is, one thing I'd love to do is to be able to show you in 3D where this nerve runs, but I'm going to be relying on my collection of images to try and do that. So here's the medulla oblongata. Brainstem, pons is the bulgy bit, medulla oblongata is the next bit, and that continues as the spinal cord. And the cranial nerves are numbered 1 to 12 in descending order from superior to inferior. So cranial nerve 10 is one of the last cranial nerves to leave the brainstem before it becomes the spinal cord, and then we have spinal nerves. The vagus nerve, like most nerves that need a lot of work, is a very mixed nerve. It's going to innervate some skeletal muscles, some somatic muscles, some things that you can control, some things that I'm controlling right now. It's also going to innervate a lot of smooth muscle. So the vagus nerve, its most famous role is that it is the nerve that carries parasympathetic innervation to most of the trunk. So with parasympathetic innervation, we're talking about autonomic motor innervation to, you know, automatic stuff that we can't think about, like the smooth muscle of the GI tract, the glands of the GI tract, the heart, the lungs, things like that, right? But when we talk about parasympathetic innervation to the body, we talk about craniosacral sources of parasympathetic innervation. The cranial part then is there are a few cranial nerves that send parasympathetic innervation out from the central nervous system. The vagus nerve is the biggie, so that's going to carry parasympathetic innervation down into the neck, into the thorax, into the abdomen, and the sacral origin of the parasympathetic innervation is from the sacral spinal cord, levels S2, S3 and S4. There are parasympathetic neurons in there that leave the spinal cord and they run to the pelvis. Do you see? So we have the sacral part and then we have the cranial part, the vagus nerve and the sacral, and they kind of meet. And we'll talk about the textbook's descriptions of where they meet, but some recent research questions where the overlap is, and maybe it's a bit muddier than we realised. Anyway, skeletal muscle, parasympathetic. It also carries visceral afferents back to the brain. That is sensory neurons from organs, viscera, tubes of the GI tract, that sort of thing, back to the central nervous system. It might sound like I'm being a little bit vagus myself, but what I'm leading towards here is that in the brainstem there are nuclei. A nucleus is a collection of neuron cell bodies that are going to send very long axons out from. We call them a nucleus most of the time in the central nervous system. We call that collection of nerve cell bodies in the peripheral nervous system a ganglion. So essentially the same thing, just a collection of nerve cell bodies. The cells are going to send, those neurons are going to send their axons out from there. So the dorsal motor nucleus of the vagus is the origin of most of the preganglionic parasympathetic neurons that the vagus is going to carry. The nucleus of the solitary tract, sounds like a novel, doesn't it? That's going to receive most of the visceral afferents that the vagus nerve is carrying back to the central nervous system. And another cool name, nucleus ambiguus, but not spelled as you would expect, got those two U's there, which makes it extra cool. The nucleus ambiguus, that's the origin of the skeletal muscle innervation. That's the origin of the neurons that are going to innervate the skeletal muscles that the vagus is going to carry fibers to. So that those are muscles that we can consciously control, somatic. Phew, that's the major neuro-y stuff out of the way. Get on to more comfortable ground now. Right, so the vagus nerve is going to leave the cranial cavity by passing through the jugular foramen. The jugular foramen is kind of this big ugly hole, and the reason it's a big ugly hole is because there are lots of things going through it. This is where most of the blood will drain from the cranial cavity. It'll leave with the internal jugular vein, which passes through the jugular foramen, or kind of forms there where the dural venous sinuses meet. And then cranial nerve 10 is going to go through there. Okay, the easy way to remember this is cranial nerves 9, 10 and 11 pass through the jugular foramen. Okay, and the vagus nerve is 10, so that goes through there. Now, from there, on the other side, so on the base of the skull, we've got the jugular foramen and the carotid canal, the opening there, they're right next to each other. And in the neck, the internal carotid artery, which comes from the common carotid artery, will run with the internal jugular vein in the neck, nice and deep, well protected by these big muscles of the neck. The vagus nerve runs with those blood vessels within a tube of fascia called the carotid sheath. So whenever we're dissecting here, what we when we eventually get through these layers, we find that layer of fascia, that tube, the carotid sheath, and if we cut it open, we find in there, you know, down at this level, we'll find the common carotid artery, the internal jugular vein, and the vagus nerve. Guaranteed. So that's where we always find it, and then we can start tracing it to see where it goes. Alright, okay. Before we get that far though, there's actually quite a lot going on in the neck. But before it gets into the neck, the vagus nerve sends off an auricular branch, auricle. So the auricle refers to ear. An auricular branch carries a little bit of sensory innervation from the skin inside the ear hole there. That kind of external auditory meatus skin. That's like, it doesn't have many somatic sensory jobs. Okay, so there's another thing. It carries somatic sensory innervation back. But yeah, so... And there are some studies that suggest you can stimulate the vagus nerve by stimulating the skin in this region. Don't know how good that is. There is some good work there, kind of small studies, not entirely sure yet, but auricular nerve to there, all right? The other thing it does while we're up here is it carries sensory branches from the dura mater, from the meninges surrounding the brain. It's a little bit of a trick because I think those fibres are actually running to the dorsal root ganglia of like cervical spinal nerves, but they just run with the vagus nerve. So it's not really vagusy, but it kind of is. The reason innervation of the meninges is interesting is because often it's implicated in headache. Headache is this big thing of, you know, it's not entirely sure why all headaches occur, not entirely sure how to treat all headaches, blah, 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 blah. So this is part of the anatomy of headache. Little sensory nerves running from the dura mater, that's the thick connective tissue covering of the brain, with the vagus nerve back to the central nervous system. I always joke to students that you could write an essay about the vagus nerve, no bother, and I thought this was going to be a short video, but no, it's just too much fun. There's too much going on. Right, so as the vagus nerve runs down in the neck, if we go from superior to inferior, it sends off some motor branches to the pharyngeal plexus. So the pharyngeal plexus is a plexus of nerves. So a plexus is like loads of fibres kind of running together and stuff. There's no connections or anything, they're just kind of running together around things, with things. So the pharyngeal plexus is going to innervate most of the muscles of the pharynx. That's important in swallowing. But it's also, the vagus nerve is going to innervate all of the muscles of the soft palate, which is the hard palate is the bit you can feel next to the bone. If you go a little bit too far back, you get the gag reflex, which is important. That's the soft palate, and that's muscular. That's a muscular roof. All of those muscles except one are innervated by the vagus nerve, and then you see the uvula hanging down, right? Now this is important for two reasons. One is the safe swallow, and we'll talk more about the safe swallow again later as we work our way down, if I remember. So the vagus is important for the swallowing action there, the movement. So when you swallow, you know, the bolus of food gets pushed to the back of the oral cavity. The soft. Anyway, I'm not good. Oh, getting too Vegas, aren't I? Okay. When you open your mouth and say ah, you can see the soft palate and the uvula in the middle. Ah, right? Now, if the vagus nerve on both sides, because there are left and right vagus nerves, of course, if they're both functioning and innervating the soft palate, then the soft palate is raised evenly, normally. Ah, go and have a look in a mirror, check it out. Ah, and the uvula is in the middle. If the nerves innervating the soft palate on one side are weak, they won't lift the soft palate, so it'll drop, which means the uvula is going to point that way. It's going to point to the strong side, right? So you need to have two functioning vagus nerves for the soft palate to get raised on both sides. If the vagus nerve is not functioning on one side, it won't be lifted evenly. So that's important. The other one is the gag reflex. So the glossopharyngeal nerve is sensory at this point. Oh, there's so much cool embryology about this as well. But so the glossopharyngeal nerve is sensory, kind of like at the back of the mouth, at the oropharynx. And of course, if something unexpected usually pokes the back of the oral cavity or the oropharynx, then that triggers the gag reflex. The glossopharyngeal nerve is the afferent limb. The vagus nerve then is the efferent limb. It's the motor limb. That then causes the and what's it? Yeah, that's the pharyngeal muscles that are then causing that gag reflex. So that's a safety feature, isn't it? To stop things going down the airway, because the foodway and the airway share the same tube for some daft reason. So it's kind of a built-in safety reflex that doesn't always work. The gag reflex can be modulated as well. You can lose your gag reflex completely normally. You can train yourself out of it and you can regain it later. So an absent gag reflex isn't necessarily pathological. The vagus nerve also carries a little bit of taste sensation from the very posterior part of the tongue. But we don't tend to talk about it. We don't like to bring it up because the innervation of the tongue is complicated enough as it is without bringing the vagus nerve into it. So if you forget that bit of information, that's probably fine. As we descend from the pharynx to the larynx, the vagus nerve becomes more important. The vagus nerve is going to innervate all of the muscles of the larynx. So these muscles that I'm using right now to move my vocal cords and what have you, to make sound, those muscles are all innervated by the vagus nerve. There are a couple of branches. We have the superior laryngeal nerve, which becomes external, has external and internal branches, and then we'll see the recurrent laryngeal nerve coming up later. But that's a whole other larynx topic. But the vagus nerve is motor to the muscles of the larynx, and now it's also sensory to the mucosa inside the larynx. So a safe swallow also really includes the closing of the vocal folds, and the muscles that do that are controlled by the recurrent laryngeal nerve, a branch of the vagus nerve. So the vagus nerve is important in a safe swallow. If the vocal folds don't close fully, then you could get some fluid and bits and bobs down the airway into the lung, which will lead to infection, pneumonia, bad things. So it innervates a lot of things as it goes down through the neck. Right, and I said it's running with those blood vessels, isn't it? So the left and right vagus nerves are going to take slightly different routes now, because as we get into the thorax, it's a little bit asymmetrical, isn't it? We have the aortic arch going off to the left, the brachiocephalic trunk going over there, the superior vena cava is over to the right, and so on. So on both sides, the vagus nerves will continue and they'll run anterior to the subclavian arteries. Which one should we do first? So the one on the right, essentially, remember this, the vagus nerves are trying to get to the GI tract. So they're going from here and they're going to try and get to the esophagus. That's what they're going to do. So if you think about where the esophagus is in the thorax, so the right vagus nerve then runs anterior to the subclavian artery, and then really it's gonna run posterior to the hilum of the lung. All of those blood vessels that are going between the heart and the lung and the airways, the vagus nerve is going to run posterior to that and dive down to the esophagus. As it goes past the subclavian artery, that's where the right recurrent laryngeal nerve leaves it, loops around the subclavian artery, and that's going to run back towards the trachea and then back up to the larynx, because the recurrent laryngeal nerve is going to innervate those muscles of the larynx, right? Left. Okay, on the left we've got that big feature, the arch of the aorta. Ooh, it's got a job to do there actually. So what it's going to do is, again, it's going to do kind of the same thing, but it's going to run from anterior to the left subclavian artery. It's going to run kind of a little bit laterally. It's going to go to the arch of the aorta, and it's going to run around it, and then it's going to run again posterior to the hilum of the lung, where all the things are going to and from the lungs, and then it's going to run down to the esophagus. And then both vagus nerves will follow the esophagus down to the abdomen. But the aortic arch, right, okay, baroreceptors. So blood vessels, the arch of the aorta is a really good one because there's a lot of blood and a lot of pressure there. But baroreceptors are stretch receptors in blood vessels, and so they are connected to the central nervous system by visceral afferents, yeah, because this is viscera, and the baroreceptors, when they fire, they'll send that sensory information back via the vagus nerve back to the brainstem. Okay, so the vagus nerve is involved in the baroreceptors of the aortic arch. There are also baroreceptors up in the carotid sinus. Those go back with the glossopharyngeal nerve. Off topic. Okay, where are we? We're in the thorax. So the vagus nerve is going to carry parasympathetic innervation to the major organs in here, the lungs and the heart. So parasympathetic innervation to the heart will cause a decrease in the heart rate. It'll cause a decrease in the force of contraction. So normally the sinoatrial node of the heart, if you just took the heart out and looked after it, the heart would beat at about 100 beats per minute. Me, I'm sat down, my heart rate is 90 beats per minute. My God, I really must be using my brain. It's usually about 60 when I'm sat here. So that's the parasympathetic nervous system. The vagus nerve driving the sinoatrial node also hooks up to the AV node, also hooks up to other bits of the heart to reduce the heart rate and the force of contraction, to reduce the rate of blood being pumped around the body. The airways to the lungs are surrounded with smooth muscle. There are glandular secretions in the airway as well. So there is parasympathetic innervation also to the lungs, to the airways and to the lungs themselves. And then we have visceral afferents running in the opposite direction. So sensory information being collected from the lungs and from the heart runs back with the vagus nerve back to the brainstem. So there are a number of plexuses here. They kind of all overlap a little bit. So as I said, a plexus is nerves just running together, crossing over each other, forming a bit of a meshwork. They're not connecting with each other. There aren't synapses there. They're just kind of running together. It's kind of like cabling. So there's a cardiac plexus, there's a pulmonary plexus, and these plexuses are actually made up of sympathetic fibres and parasympathetic fibres. So the parasympathetic fibres from the vagus and the sympathetic fibres from the sympathetic trunk kind of run together here because they want to get to the same targets: heart, lungs, that sort of thing, right? And then the vagus nerves running with the esophagus, they're going to form esophageal plexuses as well, which is kind of the theme that we see throughout the GI tract. And to be honest, we're almost done now with the path of the vagus nerve, because the esophagus is going to run through the diaphragm. The vagus nerves, left and right to start with, they run through the diaphragm as well, and these plexuses run through the diaphragm with the esophagus. They don't innervate the diaphragm. What innervates the diaphragm? That's right, the phrenic nerve innervates the diaphragm. There are some other sensory bits and bobs, but it's not the vagus. The vagus is it's innervating the GI tract, so it's running with the esophagus through the esophageal hiatus. Hiatus, like a gap, isn't it? In the diaphragm to get to the stomach. Now, one note here is that in the embryo there was a nice simple early gut tube, and obviously it's got a lot longer and folded and more complicated. And one thing that happened during the embryological development of the gastrointestinal tract is that the stomach rotated that away, which means that the left vagus nerve gets pulled anteriorly onto the anterior surface of the stomach, and the right vagus nerve gets pulled around posteriorly. Now, the gastrointestinal tract kind of has its own little brain, the enteric nervous system, and that in itself is a bit of an oversimplification, in that the gastrointestinal tract has a lot of hormonal control, or hormonal regulation, signalling, chemical stuff going on here. Really, really clever, beautiful stuff that regulates it. And the enteric nervous system is kind of the collection of nerves surrounding the GI tract, also involved in regulating the processes of the GI tract. So the vagus nerve carries parasympathetic innervation, which can have an effect on those processes. So we say parasympathetic innervation causes rest and digest processes. So parasympathetic innervation will drive up the motility, the activity of the gastrointestinal tract, glandular secretions and squidging food through and that sort of thing. Whereas the sympathetic nervous system will kind of do the opposite. It'll limit blood flow and blah, blah, blah. But there's so much beautiful physiology to it, I should just leave it as that. Now, so the vagus nerve is carrying parasympathetic fibres to the GI tract, which is kind of having an effect on the enteric nervous system, kind of like it has an effect on the sinoatrial node in the heart. How far does it go? Well, the textbooks describe the vagus nerve as travelling, following the GI tract, as far along as about the left colic flexure, so the transverse colon, where it becomes the descending colon, that left colic flexure is probably as far as the vagus nerve reaches. And then that sacral parasympathetic innervation from the spinal cord is coming up from the pelvis and is innervating the remainder of the GI tract. And that makes sense because embryologically that's where the midgut becomes the hindgut. So the blood supply is also different here and so on. Okay, so that means, you know, if you take it at that, is that the vagus nerve can have an effect on most of the GI tract, but probably not the last part. There's bound to be a little bit of overlap. So it's not carrying parasympathetic innervation to the viscera of the pelvis. For example, the parasympathetic nervous system causes erection of external genitalia, and that's under control, or that parasympathetic innervation comes from the sacral spinal cord, not from the vagus nerve. But there is some suggestion that visceral afferents, which run with the vagus nerve, may reach as far as the pelvis. But, you know, work is ongoing, as usual. This is what's, you know, this is the beauty of biology and science, isn't it? How's that? Can you describe the route of the vagus nerve now, from the brainstem through the jugular foramen with the blood vessels down into the thorax to the esophagus and through into the abdomen through the diaphragm? If you can, top notch. So the vagus nerve is a peripheral nerve, like other nerves. It's very mixed, and really it's a bundle. It's like a bundle of cables, isn't it? It's just a structure carrying neurons from some nuclei in the central nervous system to external structures, and vice versa. That's all it is. Now there are a couple of interesting things we can talk about. Vasovagal syncope is something you may experience if you're studying anatomy in a lab. So vasovagal syncope is, alright, if you're in a really stressful situation, sometimes the parasympathetic nervous system works a little bit too hard. The heart rate goes down, blood vessels dilate, the body doesn't do a really good job of pumping blood up into this closed box. There's a whole bunch of interesting pressures involved, which means that kind of not enough blood goes to the brain. It, you know, it kind of falls down to the abdomen, pelvis, legs and that sort of thing. And when there's not enough blood going to the brain, a lot of people get this at the sight of blood. I sometimes get it with students the first time they meet a cadaver. And it's purely a physiological thing. There's nothing you can do about it. It's not your fault. Don't feel embarrassed. It's totally normal. It means that you're normal. Yeah, it means that this is kind of what should happen. It just doesn't happen to me anymore because I'm not very normal. So that's vasovagal syncope. Vaso, blood vessels. Vagus, yeah. And I think the most important thing to talk about here is that medical students or other health profession students who experience this, they really start to worry and they think, I'm not going to be able to be a nurse, a doctor, or whatever because I can't handle the sight of blood, or I'm not going to be able to study anatomy because I can't cope with the cadavers. And in every situation where I've seen this, the students have adapted and they've got used to it, and after, you know, we have them for 3 or 4 or 5 years, right, they're fine. And they go on to do the profession they want to do absolutely fine. They get through it. It's not a problem. It's not very nice. And a lot of this is because of exposure, repeated exposure, careful exposure. Certainly with anatomy and dissection, I can do a few things where we do stuff together and it's all right. It's okay. So that's vasovagal syncope. Fainting, because I mean, it's not really the vagus nerve's fault. That's just carrying the neurons, right? Am I really wandering now? Comfy chair and a cup of coffee, see? Right, another question. if someone has chronic peptic ulcers, that is that their stomach is producing too much acid, it's been doing it for years, ulcers in the stomach and ulcers in the duodenum are dangerous, how might you get the stomach to produce less stomach acid? Bit of a trick question that. But because this is a video about the vagus nerve, you could cut the vagus nerve, couldn't you? So if you cut the vagus nerves, then the parasympathetic stimulation to the stomach wouldn't stimulate so much gastric acid to be produced, so you'd solve the problem. So you can either cut the vagus nerves, or you could cut the branches that have left the vagus nerve that are going to the stomach. And that used to be done, so that's a vagotomy. It's not done so often nowadays because there are good pharmaceutical interventions. There are drugs that can do the same thing, so they don't need to do the surgery, certainly not as much. But you know, if you hear about vagotomy, that's the purpose of it, okay? Obviously you want to do it after it's done all its other jobs, right? You wouldn't want to do it up here, you want to do it down here. But that's it. Now hopefully you have a good understanding of the anatomy of the vagus nerve. Maybe I could write a very short essay. Anyway, right, let's... Oh God, gotta stop. I hope that was useful. See you guys next week.